All right. Thank you, everybody, for joining us today for the Ultrasound Grand Rounds this week. This is going to be kind of a fun and exciting day. We're actually wrapping up the last lecture for this academic year, or this calendar year, the year 2022, today. And we're definitely going to go out with a bang, with a really, really good topic. I know we've talked a lot of good things. They've been, we post them on the YouTube channel. So if you watch this through the YouTube channel, thanks for watching and, subscribing and all that. But today we're going to finish up kind of some conversations that we're having about advanced cardiopulmonary topics. So last week we had Dr. Shaman from the MICU talking about some pulmonary hypertension issues and how we assess that on the left ventricular side. And today we're going to slide on over to the right ventricular side and talk about RV function, or RV dysfunction, as it were, with relationship to pulmonary hypertension, with a good friend of mine, one of my colleagues, Dr. Ashish Aneja, who's been on this forum before. He's one of our cardiologists, and he's a wealth of knowledge, and hopefully will illuminate some stuff for myself and for you guys, and we'll all learn something together. So with that being said, Ashish, welcome. Thank you for joining us today, and for being a part of today's conversation. I know you're taking some time out of your own personal life, and hopefully this will be valuable to everyone who's joining us today. So thanks for being here.
Thanks for the invite, Matt. It's always a pleasure.
So let me just, for the sake of completeness here, just put up the title slide. So today we're going to talk a little bit about I think we're ultimately going to get to this whole concept of using the RVOT, right ventricular outflow tract, VTI, or velocity time integral, in assessing these patients with pulmonary hypertension. I think it's kind of where we're ultimately going to land. That's kind of my goal. But we have a couple steps to get there to maybe make this understandable. So for those joining us, I put up Ashish's information. Ashish, I think you actually just humorously have achieved the recognition of having more digits in your titles than in your name. So congratulations. I was typing that out and noticed that you had a lot of titles behind your name. And so that's quite an accomplishment on your part. Certainly something I have to aspire to, though. I think my name's longer, so I have a little bit more work to do.
Yeah, it doesn't really do anything for you. It's just that it shows how many societies I pay dues to every year. That's all it does.
All right. Well, needless to say, congratulations on your accomplishments. But let's kind of dive into today's talk. All of this really stemmed from a conversation that I had on, I believe it was on Twitter, with someone who watched our previous video that we did on this topic and then asked a question. And I thought it was a really great question. And so if you remember back, probably almost a year ago, we did a conversation about, does the RVOT VTI help differentiate severity of pulmonary embolism, right? And there's a study that basically showed that it correlates with cardiac index, and that if you have a RVOT VTI below a certain threshold, they tend to be more severe PEs than if they're above a certain threshold, right? And I thought it was interesting. It's certainly not a technique we do all the time, but it kind of piqued my interest because it's Doppler and it's fancy and it's cool, right? And so there was a guy who responded to me on Twitter saying, hey, this is interesting. Can you use RVOT VTI to differentiate PE, acute PE, from chronic pulmonary hypertension, right? Because both of them are kind of a hypertensive state, but there's definitely an element of chronicity that's involved, that we definitely see played out like in things like the 60-60 sign. So can this be a surrogate for the 60-60 sign and kind of making this determination? And I thought it was an interesting question. And one that I don't know if I completely fully understood at the time. And so I think with, we're going to try to tackle that one today and just kind of address that issue. Can we use the RVOT VTI to differentiate acute PE versus chronic pulmonary hypertension? But to set the stage, to kind of set up the conversation, I think we need to go back a little bit and define some terms, right? Review a little bit of physiology, a little bit of basic echocardiography, or maybe some advanced Doppler echocardiography, and then readdress this question towards the end, right? So I'm just going to set it up here, and then just let you run with it here for a bit, Ashish. But basically, pulmonary hypertension is kind of we've been talking about a little bit in the last several weeks, and I don't want to go into all the details, but pulmonary hypertension is an entity that exists with elevated pressures in the pulmonary vascular system, as opposed to in the systemic system, which is what we're really accustomed to in the emergency department and critical care environment. But by definition, it is a mean pulmonary artery pressure greater than 25 millimeters of mercury at rest, right? Now, how we get this is kind of a complicated discussion, ultimately probably best done with the right heart cath. But there's some formulas that can be utilized. This is one I happened to find in an article this morning where you can basically take your systolic artery pressure, pulmonary artery pressure, which you can calculate with echo, and run it through a formula and get a rough estimate of your mean pulmonary artery pressure. And then just kind of the quick and dirty, the ED bedside method is if your tricuspid regurg velocity jet is greater than 3.4 meters per second, that's going to end up calculating out to be this high pulmonary artery pressure. And there's ways we can get to that. I'd point you towards the video that we have on YouTube from Dr. Shaman, where he goes through all of this in depth, but just a rough baseline, that's going to be kind of a rough definition of pulmonary artery hypertension, right? Or pulmonary hypertension. Now, to classify this, to break this down, we've talked about it in the context of the WHO classification, which really defines what's causing it, right? So type 1 is primary pulmonary hypertension, right? Something wrong with pulmonary vascular system. Type 2 is hypertension secondary to left heart disease. Type 3 is going to be due to chronic lung disease, right? Type 4 is due to chronic thromboembolic disease, which kind of is where we're headed a little bit. And then type 5 is doesn't really fit any of those categories. And so we have to create a type for it, right? And that's just everything else. Now, what I've noticed when we discuss this in the literature is it's described as precapillary and postcapillary pulmonary hypertension, which is oftentimes reflective of more of a physiologic understanding than an ICD-9 or 10 or a diagnostic understanding, which is what I think the WHO is getting at. So with that said, Ashish, let's talk briefly about pre and post capillary hypertension. And I think I'll just set the stage and define it. Pre-capillary hypertension is when when you just look it up in the literature, is defined as a pulmonary capillary wedge pressure less than, I think it was 15, and post capillary is a pulmonary wedge pressure greater than 15 millimeters of mercury. But practically speaking, from a physiologic perspective, what does that mean for us and for the patients that we experience?
Yeah, so thanks for setting the stage. I think you started this brilliantly. So the WHO classification makes sense because it really determines how we treat the patient. And that's the whole point of the WHO classification, right? So when we talk about primary pulmonary hypertension, we're talking about something wrong with the pulmonary arterial tree itself. So we're talking about reduced compliance of the pulmonary arterial system. We're talking about things that may be potentially wrong at the capillary and the arteriolar level, mainly the arteriolar level. The arterioles, which are branches of the pulmonary artery, start to thicken up and develop thrombosis and fibrosis and stuff. And it reduces the compliance of the pulmonary arterial system and raises pressure in the pulmonary arterial system, but spares the pulmonary venous system, which follows the pulmonary arterial system. So if you think about it, the right ventricle sends blood to the pulmonary artery and then divides into arterioles. And then the arterioles, which are in the lungs, come back as capillaries. And then the capillaries become venules and they become veins. And then it attaches to the left atrium. So whatever comes before the capillaries is precapillary, right? And whatever comes after the capillaries, which is the venous system, is postcapillary. So the venous system, the pressure in the venous system, as you can imagine, is all determined by the left side of the heart, right? So the left side of the heart, you could have an elevated pressure at the level of the left ventricle, right? So that's the most common cause when you have an elevated left ventricular end diastolic pressure or interchangeably elevated left atrial pressure, assuming that there's no mitral valve disease, right? So if you had no significant mitral stenosis or regurgitation, you would argue that the high left ventricular filling pressure is what's causing pulmonary venous hypertension or post-capillary pulmonary hypertension. So if you understand that, the rest of this becomes really easy. And I'm sure people that are listening and kind of get that.
And we spent a long time last week talking about that very entity, right? The post-capillary pulmonary hypertension. If you need to get a refresher for anyone's listening, go back to the video. It's on YouTube. We have a good discussion with Dr. Shaman about that.
Yeah, we're not going to talk too much about that. But if you did have mitral stenosis, for example, most of your elevated pressure is coming at the left atrial level, or if you had cor triatriatum, which is even higher than the mitral valve level, you could have elevated left atrial pressure, which leads to a high post-capillary pressure, and that really spares the left ventricle. So if you took a catheter into the left ventricle in MS patients or mitral stenosis patients, you'll find that the left ventricular pressure is normal, but the left atrial pressure is markedly elevated. So moving back to the and that's type 2, right? And then we're talking about group 1, which is primary pulmonary hypertension, which is often idiopathic and is more common in women. When we talk about the typical idiopathic pulmonary hypertension, was classically described in young women in their 30s and 40s. And then we used to talk about how it is responsive to calcium channel blockers and not responsive to calcium channel blockers. There's a small group of patients that actually still respond to calcium channel blockers. It's a very small percentage, and that's all determined in the cath lab. And those patients tend to do really well, but they are the exception and not the rule. But the vast majority of patients require other treatments when we're talking about primary pulmonary hypertension. And this is, as I had previously mentioned, reduced compliance of the pulmonary arterial system as a result of fibrosis and thrombosis. And there's so many description and so many other details that you can read on your own. But the treatments really consist of prostacyclin therapy and endothelial antagonists, largely speaking. And you can also talk about PDE5 blockers like sildenafil. So that's where these drugs really work. Group 3 is due to lung disease. So basically, you have bad COPD or anything that leads to hypoxemias, including interstitial lung disease. We're talking about hypoxemia-induced vasoconstriction of the pulmonary arterioles, and that sort of leads to the same consequence as group 1 does. But there are differences in pulmonary arterial compliance, as you can imagine, because the disease process doesn't directly involve the pulmonary arterial tree. Group 4 is chronic thromboembolic pulmonary hypertension, which this group is very familiar with. And that tends to be, again, this is really precapillary because we're talking about the mechanical obstruction of the arterial tree. You have, and it depends upon the chronicity, really, how pulmonary hypertension develops in this group. In patients with an acute pulmonary embolism, and this has been discussed previously, the peak pulmonary arterial pressure tends to remain below 60 systolic, whereas in patients with chronic thromboembolic pulmonary hypertension, because there's remodeling of the pulmonary arterial tree, the pressure tends to be above 60. And there is things that we can use to distinguish between CTEPH and an acute PE, but with echo, we have a lot of limitations if we're asking to distinguish between acute and chronic PE. Of course, the 60-60 sign being one of them. Yeah. And then group 5 is this large basket, which has mostly precapillary causes. So yeah, I mean, we're talking about sarcoidosis and schistosomiasis and things of that nature. So yeah, I mean, that's broadly speaking. Is there anything else you'd like me to talk about, Matt?
So I think, it kind of goes without saying that, precapillary, well, let's say post-capillary, we're going to see LV findings on echo, right? That's because that's what causes it. Precapillary, then, I guess by inference, would say that you shouldn't have any LV findings on echo, correct?
That is correct, yes. But
so then the question, go ahead. No, the question that I had is, then now we're looking at the RV, right? And so if we, to differentiate types 1, 3, and 4, which is really going to be a lot of our main precapillary pulmonary hypertension, will there be a lot of echo differences, or do they all are they echo similar?
No, they're remarkable differences, and that's why this talk is, this discussion is very important. We can, do you have any slides about that? Or are we going to talk, should I share my screen? Do you have more slides, Matt?
I have a couple slides coming up here about some of the different echo things that we can look for through valves. So if you want to do that now, or we could come back to that in a minute.
However, you lead it. I'm fine with the jumping right into the echocardiographic differences between say pre and post.
Sure. Let's do that for a minute, just so that we can be all on the same page in terms of what echo parameters we're looking at here, and then then the floor will be yours, Ashish, and run with it.
Yeah.
So a couple weeks ago, we did a talk about advanced Doppler findings. And for those of you who want to go look at that, go back to the YouTube channel. It's 4 or 5 videos back. And we basically went through some, how do you assess the heart using Doppler, and kind of what does Doppler mean, kind of the baseline, assumptions in Doppler, and kind of how to interpret the packets. But I wanted to really illustrate 3 particular Doppler parameters that we can measure that will be helpful here. And if you want to add anything, Ashish, you can feel free to talk about something else. But really talk about these and kind of how we can manipulate these a little bit. And then, that will come into play later. So the first parameter that we can measure is the Vmax, right? The velocity, the maximum velocity through whatever channel that we're measuring. So, when you think about Doppler, you think you're measuring blood flow through something, right? So whether it be through a ventricle, through the atria, usually through valves, right? Or through an outflow tract, which is what we're going to do in the RVOT or the LVOT. But we want to know flow through that. So if you think about a whole bunch of just blood rushing through there, and we're going to measure a bunch of things, right? And the first thing here, one of the most easy things to get your mind around is the maximum velocity, right? And so imagine kind of back in medical school, you have that blood vessel with the laminar flow through it. You have the fastest moving stuff in the middle of the vessel and the slower moving stuff at the periphery, right? And then whatever that velocity is on that arrow that points from left to right, that's kind of what we're measuring here. So you put a caliper through your channel, right? And either with pulse wave or continuous wave, and there's specific things about each of those, but you can measure that and you can see how fast the blood is flowing. And you can basically do from the baseline up to the highest, measurement there. And that gives you a centimeters per second velocity, right? So that's kind of the first one. And I guess, Ashish, we're going to go with all 3 of these. We'll briefly just say, what can we do to make that faster or slower? Like what things will make it faster or slower? Or if it is slower or faster than you expect, what things are you thinking about, right? So if we go, let's say we're measuring this through, in this context, the RVOT, right? Or you can even let's make it simple, just through a valve, right? Through a mitral valve or tricuspid valve. When we measure that velocity, what do we do to that valve to make that velocity go up, and what do we do to make it go down?
So, so in this case, you're looking at the left ventricular outflow tract.
Mm-hmm.
And this is a pulse wave Doppler. You see these 2 parallel lines in between these dotted sort of line, which is telling you the direction of flow. And I'm sure this group knows, but pulse wave Doppler is used to localize flow in that particular in that location. So that's the difference between pulse wave and continuous wave Doppler. Continuous wave Doppler tracks velocities all along its path and to pick up the fastest and the slowest. Typically, the fastest is what overshadows everything.
Mm-hmm.
So in this instance, the velocity is placed right just below the aortic valve, it seems like,
Mm-hmm.
and it's picking up velocity at the left ventricular outflow tract level, specifically speaking.
Mm-hmm.
So what can make this go up and down is really dependent upon the left ventricular or right ventricular ejection dynamics. It is also dependent upon the volume of blood that's being circulated. So the velocity will go up in a hyperdynamic state. It will go up in tachycardia. It'll go up if there's any kind of obstruction, right? So those are the 3 things that make the velocity go up. Things that make the velocity go down are depressed cardiac output state for the most part, right? So if you have less blood coming out, the velocity is going to be lower. And from the technical standpoint, it can depend to some degree upon where the Doppler signal is placed in terms of the pulse wave Doppler, right? So if you get really, really close to the valve, you're going to sort of continue to increase the velocity, and it can start to alias. So pulse wave Doppler velocity peaks at 2 meters per second. So if anything's going above 2 meters per second, you're going to start see aliasing. A continuous wave Doppler can detect velocities up to 9 meters per second. So it does not alias. In other words, it does not wrap around the baseline. So yeah, I mean, that's basically what we have. In order to get a proper, if in order to get a proper signal, say across the aortic valve, you want to move your pulse sample volume at a location where you can actually see the aortic valve or the pulmonary valve closure click, which is about a centimeter below the valve, which is where you have the zone of flow acceleration, and you want to really put your velocity at that point. So that's one of the fine-tuning aspects. So that you got to be careful about. You know, in a very calcified aortic valve, you may not have the closure click, but pulmonic valves don't get calcified. You should really be looking for that closure click, which is at the end of ejection.
Yeah. So I think to summarize it, basically your preloading conditions, it sounds like, can affect your velocity, right? Your, I guess maybe stroke volume, or kind of your, inotropic effects can affect your velocity, and then even like your channel size, right? So if you have a stenotic versus non-stenotic, all those things can affect your velocity. And so it really becomes a complicated milieu of what are the clinical conditions that we find in our patient, whether hyperdynamic, hypodynamic, they have stenosis, no stenosis, things like that. Does that
right? So
sound
preload, yeah,
fair?
like you said, preload, afterload, and the inherent contractility, and some of the technical factors. So those all in combination determine the flow velocities at any point.
Sure.
In the
So the next one then is acceleration time. We see this one in the literature from time to time. I know it's part of the 60-60 sign. In this example, again, we're in the same area, right? I just had a nice Doppler packet, so I used it, right? So there's nothing clinically specific about this particular image, other than it happens to be the LVOT again. But if you think about it, the heart is not, unless you have an LVAD, it's not a continuous pump, right? It's you probably have a better vocabulary word, Ashish, than I do, but it's a non-continuous pump, right? It's on, it's off, it's on, it's off. And so you're going to have periods of time when you have, zero velocity, and you're going to have times where you have peak velocity, right? And so to get from, zero velocity to peak velocity, you have to accelerate. So you're having acceleration time, and the amount of time that it takes, your 0 to 60 time, essentially, from when you get to nothing to something, is going to be your acceleration time, right? How fast can you get from 0 to 60? And so I guess the question on this one then becomes, Ashish, for you, like, what are the clinical parameters that will shorten that acceleration time? And what are the clinical parameters that prolong the acceleration time? And I think, let's assume that there's technical factors are all perfect, but clinically, what could make that difference?
So if the arterial compliance is normal, then it's going to take its own sweet time to accelerate, right? So that means the equilibrium state is reached much sooner if you have a stiff arterial system, right? So when the chamber starts to eject blood, and in this instance, we're showing the LV, but just assume for a moment that this is the right ventricle and the right ventricular outflow tract. It will take its time. The right ventricle, it doesn't work like the LV, so the acceleration time of the right ventricle is always going to be slower, right? Because it sort of even milks the blood. The LV is the thick muscular chamber, so the acceleration time on the LV side is always going to be quicker. And the pressure in the aorta is always higher, right? That's your blood pressure. And that's why you'll always tend to see an early peak on the left side of the heart, right? So it's both those factors. So we're talking about the afterload, we're talking about the compliance of the vessel, we're talking about the contractility on the right ventricular side. The pressures tend to be much lower, so the acceleration time tends to be much slower, right? So it's often in the 120 millisecond range. And if it starts to drop below 90 milliseconds, we're talking about a stiffening of the arterial system, or we're talking about an elevated pressure overall. And we'll get into those details in subsequent slides or subsequent part of the discussion. So yeah, I mean, those are the major things that we're looking at.
What about preloading conditions? Does that affect your acceleration time?
No, it shouldn't affect your acceleration time, assuming the contractility of the chamber does not change. It really shouldn't make a big difference.
Sure. And then the final parameter that I wanted to look at was something we've talked about, and kind of where we're going to end up with this conversation is the velocity time integral, right? And so we talked a little bit, I don't remember if it was in the video last week or if it was on rounds, about the difference between ejection fraction and VTI, right? How they kind of are affected by similar things, but they are different measurements of things, right?
Yeah.
And so my understanding of VTI is that basically we do a Doppler packet through, in this situation, the left ventricular outflow tract. We're going to talk about it in the right side, the right ventricular outflow tract later. And we can measure all, like the sum total of all the velocities over that beat, right? That systolic beat. We see all the velocities, high, low, and everything in between in this packet. And if we outline that beat, as it were, all those velocities, we can use a little bit of fancy calculus to integrate the area under that curve. And that gives us the area of blood flow through that chamber, or through that channel, over that beat. And then we can do some fancy math and turn that into a stroke volume to get our cardiac output assessment. But it gives us a rough estimate of the area going through there. And then I guess I'll ask you two questions. One that doesn't make any sense for me. I'm still scratching my head on this one. And number two will be the second question that we've been asking for the other ones. So it's displayed in on the machine as in centimeters, right? The units are in centimeters. But if you're talking about area under the curve, it should be centimeters squared. So what am I missing there? Yeah. And then the second question is, what clinical parameters will raise or lower or affect the VTI?
Yeah. So factors that, let me answer the second part of the question first. Things that change the VTI are the same things that change the cardiac output. So the cardiac output is really the time velocity integral times the outflow tract area times the heart rate. Okay, so that's your cardiac output. So if you look at the, so essentially what you want to do when you're looking at the TVI, or time velocity integral, is measure only in systole, right? So you want to trace continuously the beginning of the QRS, and we don't have an ECG here, but I'll show you from what I have from a couple of papers as to what it is we're talking about. So essentially you want to trace, so in this case, these big velocities that are highlighted, there's three of them. If you look below the baseline, which have a trace around them. So you want to trace around all of systole, okay? And from the beginning of the ejection all the way to the end of the ejection. And the centimeters that we're talking about is the length of the line integrated, okay? So the length of the line, as it goes down and as it goes up, is basically telling you what the area inside that line is. So the longer the line going down and up like that, the more the ejection. Does that make sense? Okay, so and I'll show it to you in the a couple of the papers that I have. So that tells you how much blood is coursing through the outflow tract, whether it's the LV or the RV or any outflow tract that you're looking at in systole, and then you multiply that by the area of the left ventricular outflow tract, pi radius squared. So when you're looking at the LVOT, you want to determine the diameter of the LVOT. The radius is half of that. So if your diameter is, say, 2 centimeters, which is the most common diameter of the LVOT, and say your time velocity integral is 30 centimeters, right? So pi times 30 would be approximately 90. So that's your approximate stroke volume, right? So 3.14 times 30, and your LVOT radius is 1 because your diameter is 2. Does that make sense?
Yes.
Okay. So anyone have any questions, you can please stop me. But that's really how you do your stroke volume. And then you multiply that by the heart rate and say the heart rate is 100, right? So we're talking about 9 liters, okay, which is a pretty high cardiac output state. Index is how you determine the cardiac index, how you determine cardiac output, really. So 9 liters may not be a lot in someone that weighs 250 kilograms, but it may be very high in a person that weighs only 60 kilograms, right? So it really is indexed measurements that we're talking about. So this is a key measurement that you should know how to get. The difference between the LV and the RV side is that the RV outflow tract is generally bigger than the LV outflow tract in dimensions, and it is more difficult to measure because the pulmonary arterial dimensions are more difficult to visualize in echo, okay? But if there is no shunt and there are no significant differences between the LV and RV ejection, really the product of the LV outflow tract, the radius times pi times TVI, should equal the flow across the pulmonary circulation, unless you have significant valvular leaks of some sort, which sort of offsets the stroke volumes, right? So if you have a significant bit of mitral regurgitation, then you may have a lower left-sided flow than the right-sided flow, because a significant part of the stroke volume is actually ending up in the left atrium. So
maybe just we'll pause there for just a sec. Sorry to cut you off. But just to recap that a little bit, because I know we went through a lot of stuff for those who are watching us. Your LVOT VTI and your RVOT VTI are going to be two different numbers, right? LVOT VTI is generally 20 or more. RVOT VTI, if I remember correctly, is what, 15 or more? Somewhere in there. And the reason for that is the outflow tract size on the right side is bigger than the left side. So like Ashish is saying, if you do the math, right, you should get a roughly equal cardiac output from the right and from the left, right? And where that would be different is if you have some form of shunting of blood flow away from the normal direction it should go, right? So if you shunt blood from the LV back to the RV, that's going to increase your RVOT VTI. If you have regurgitants, that's going to lower your VTI on whatever side it's regurgitating. And so that could affect the differential VTI between the left and the right, if that makes any sense. And then to kind of the things that will affect it is all the things you'd expect, right? Your preloading, your afterloading, and your kind of your contractility effects of the heart. All of them can raise or lower your VTI depending on what's going on. So I think that's a good summary. Ashish, I've shared it so that you can share your screen. If you want to kind of take that from there and really add to whatever you wanted to add to it before we come back to this final question. I think we got a little bit of time here.
Yeah.
Does RVOT VTI help us in making this assessment between acute thromboembolism and chronic pulmonary hypertension? So you should be able to share your screen here.
So this is, let me find a different one actually. Excuse me. This bar is coming in between and I'm not able to. Let me make this full. This way it'll let me. Okay, here. These are all the papers that I'm going to talk about a little bit. So if you look at my screen, you'll see the various patterns of right ventricular outflow tract ejection, right? So if you wanted to trace the VTI, and this is normal, this is the normal one, you can follow a path. Oops, I don't know why it's highlighting it. I wanted to change it to that, potentially. Follow the track like this. And I don't know if you can see how it's getting highlighted here.
Yep.
You go along the edges of that, and this is purely in systole, and you follow it up all the way to the edge. And as you finish doing that, the machine will give you the number, okay? So this line is really thick. The Doppler lines that you can draw on your computer are going to be significantly thinner. But you can see that closure click at the end, right? Can you? Let me go back to the arrow. So this is the closure click right there that I'm pointing at.
Yes.
You can see. So you want to see that, right? So for example, in this, in 1B, you have that closure click. In 2A, you have that closure click. 2B, you have that closure click. 3, that's your closure click. And in 3B, that's your closure click. So that's telling you that the sample volume was placed in the proper position, right? And as you can see, I mean, this length is going to be very different than this length, right? So we're talking about, this being potentially a lower cardiac output state than this cardiac output, right? So this is going to be a higher cardiac output state, assuming that the scales are the same, right? So maybe this is 1.5 meters per second, and maybe this is 1.5 meters per second, because I don't really see what the scale is at. But assuming they're on the same scale, this is probably going to be a significantly lower cardiac output, if that makes sense.
Can
right?
you use the height of your closure click as a reference standard?
Well, so the closure click I'm talking about, say, the scale here, right?
Correct. Yeah,
So
but
the
since you don't
velocity
have that, the closure clicks are about the same image to image, and your
yes.
peak velocity is lower.
Yeah, exactly. So the closure click is just telling you that the sample volume for your pulse wave Doppler is in the proper position.
Sure.
Right. That's all you're going to get from that. But it's important to see that so that you kind of know, because that's the place where you want to measure the outflow tract as well in general. Again, that's not a hard for the left ventricle outflow tract, you want to measure it where the leaflets attach or sort of meet the outflow tract. You want to measure it exactly at that point. There were previous iterations in which some people said we could measure it up to 0.5 centimeter beyond the leaflet insertion point into the aorta, but now we only use measurements right where the leaflets insert into the aorta, because that's seems to be the most physiological. Okay, in terms of measurements that are correlated with cardiac cath, for example, right? So you want to make sure that your measurements, like at the end of the day, have no meaning if they're not accurate, right? They have to be precise and accurate, and if they correlate well with cath measurements, we really know that you're measuring at the right place. That makes sense. Okay, so that's what I wanted to show as far as the stroke volume is concerned. And let's go back to you, Matt. Was there something else you wanted to show? I'm assuming you do.
No, that's good.
Yeah. Okay. There's more stuff I have to show later, but if there's other slides you have, then we can talk about that and then sort of come to the ultimate question that you had asked at the beginning of the talk as to whether or not these patterns mean something and whether you can sort of help determine what kind of pulmonary hypertension it may be, depending upon those patterns.
Yeah, so the next thing on my agenda is to address the question. So if there's any other preparatory or contextual material that you think would be helpful, go ahead.
No, I think we're, as long as we all understand that the basic difference in pre and post, we can go to the next step, really. I mean, which is to talk about the patterns. Unless somebody wants to ask a question at this point, like if you have any burning questions, please ask, because the next part's going to get a bit more complicated. And please stop us now, because that would be the best time, because, we want to make sure that this part needs to be absolutely clear.
Yeah, does anyone have questions where we're at so far with assessing the right heart with Doppler?
No bad questions. No stupid questions allowed. I'm just kidding. There are no stupid questions.
So, maybe the question, is this a stupid question? That one by definition would be classified as a stupid question.
That's right. Yeah, I agree.
Sort of that.
Yeah, I agree wholeheartedly. So please ask away. Shoji knows, Shoji's a really bright guy. We spent some time together. So yeah, Shoji, do you have any questions?
No, so I don't have much knowledge about the RVOT VTI. I didn't use much in the clinical setting. So
okay, well, that's what we're going to touch. And John and Irina, I know you guys are all fellows, and I don't know the other folks on the line on the call, but yeah, please ask questions if you have any.
So looks like everyone today is a combination of faculty or fellows.
Okay, great. I'm sorry if I don't know some of the people who are on, so my apologies. Okay, go ahead, please.
All right, so I think that gets us back to kind of this original question of RVOT VTI, right? In the article that we read, basically suggested that it's, as I mentioned earlier, a marker for the severity of pulmonary embolus. And so if you think about it, you have a PE, and we're talking about a big one, not just one of these subsegmental that where you picked it up on CT and okay, now what do you do with it, right? We're talking about something big, right? Some potential for hemodynamic decompensation, patient untoward outcomes, and it was kind of brought up as a way of assessing these severities. And we've used these before, like, is TAPSE a good measure? Is the PESI score a good measure? And then kind of, is this a good measure, RVOT VTI? And so if you put a large burden PE in the pulmonary vascular system, we're talking about a large percentage pulmonary vascular system affected, theoretically, you're going to have you're having a sudden increased pulmonary artery pressure, right? So your pulmonary afterload will go way up. And we already described afterload as a factor affecting VTI. And it just makes sense that you'll then be pumping against a stiffer wind, and you'll get less blood flow out because you have to get a higher pressure, and the right ventricle can only support a certain pressure acutely, right? Because it hasn't had time to hypertrophy, hence why the 60-60 sign works. And so it makes sense that your RVOT VTI would be decreased, right? And then as you have chronic pulmonary hypertension, right, your RV is going to remodel. You're going to have some increased ability to compensate with increased cardiac output on the right side. And so theoretically, in someone who's got compensated pulmonary hypertension, you should have a slightly higher RVOT VTI because you can compensate by getting more blood out. You've got a stronger squeeze on your right heart. So the question is, practically speaking, when it comes down to assessing acute PE versus chronic pulmonary hypertension, does that theoretical line of thinking work, or are there too many other factors that complicate our measurement of RTO-VTI, or maybe not the measurement, but the actual VTI that we do measure? Are there too many other complicating factors that it just becomes lost in the noise, and then it just isn't, it doesn't really give us a clean discrimination between the two entities? And that's where we're going. So with that said, Ashish, go for it.
Yeah.
Take us away and kind of explain kind of how this works and why it may or may not work.
Right. So, okay. So basically, the things that I want everyone to understand are there are a couple of things. So I'm trying to simplify this. And it's actually not that hard to think about. So when the right heart pumps blood, okay, it takes its time to peak. So the normal flow pattern, which I had just shown, would look a little bit like that, okay? Although really isn't the normal flow pattern. I should say, okay, you know what? Give me one moment. Trying to find normal patterns. And these are all abnormals because that's what the papers are. They're only showing abnormals. Yeah, back to the same thing. Let's see if there's more. Okay. All right. So, I think we've kind of talked a little bit about the acceleration time, right? So the acceleration time typically is about 120 milliseconds, and that's the time it takes for the ejection to peak, right? So if you look at, say, figure 1 here, right? This is where the acceleration starts, and this is where it peaks, okay? Now, in this instance, these are all patients with pulmonary hypertension, so it may peak sooner than what it really would in a normal individual, okay? But you get the concept. So the time it takes from point A to this crosshatch mark, which I just moved, is the acceleration time, okay? All right. So that in a normal person is going to be in the 122nd millisecond range. When people develop pulmonary hypertension, what happens is that the acceleration time starts to shorten. And that happens because of two factors. Number one, the pulmonary arterial system is stiffening. That's group 1 pulmonary hypertension according to the WHO classification. And it happens because when the heart ejects blood, it goes across to the entire pulmonary tree, and then there are waves that get back reflected, okay? And as the waves get reflected back, they reach the pulmonary outflow tract again. And in a normal person, those reflected waves reach the outflow tract after the ejection has been completed. So you don't see an imprint of those reflected waves in a normal person. In someone with pulmonary arterial hypertension, which is group 1, since it is predominantly an issue of compliance with the pulmonary arterial circulation, these waves come and crash into the middle of the pulmonary arterial ejection, which is shown in image B. You see image B? And what that does, it stops the flow of blood because now the reflected waves are coming back much sooner than they would, okay? Normally they would come beyond the point of ejection, right? So you don't see them at all, right? Now you're seeing it here, so it stops the flow of blood, transiently. And then the ventricle starts to pump again as it overcomes that pressure, and you see a second notch. And that's mid-systolic notching, okay? So when we talk about mid-systolic notching, we're talking about group 1 pulmonary hypertension, okay? You can also see it in group 4, but I'm not going to confuse you with that right now. So bear with me for a moment. Now, we're talking about now we're going to talk a little bit about group C, which, no, I shouldn't say group C, image C, which is showing you late systolic notching, okay? So you're seeing the notch here, which is pointed by the arrow. And then you don't have much of a wave following that, right? So it does eject a little bit longer, but the velocity of ejection following that is pretty slow. So you can have the no-notch type pulmonary hypertension, which is image A here. You can have the mid-systolic notch, which is image B, and you have the late systolic notch, which is image C, okay? Image A, okay, which is no notch, is the one you're expecting to see in group 2, okay? In group 2, which is post-capillary, left ventricular pulmonary hypertension, you should not see a notch because the pulmonary arterial compliance and the pulmonary vascular resistance are normal, right? Because it is an issue with the left side of the heart, the pulmonary venous pressure is high, but the pulmonary arterial pressure is normal, okay? If you don't understand this, then the rest of the talk's not going to make sense, okay?
Maybe we stop and kind of just recap that. So what you're saying, if I'm understanding you correctly, is when you have decreased compliance of the vasculature, it's, well, let me just, I guess I'll use the first analogy that comes into my head, right? So, and you can correct me if I'm wrong. If I take a hammer and hit a brick with it, the hammer will bounce because I'm hitting a solid surface, and that solid surface reflecting that energy back up, and it's going to bounce. If I take the same hammer and hit a sponge with it, it will not bounce.
No,
right? Because it absorbs some of that energy.
Or just dirt, you hit a hammer into the dirt. It's just
fair enough.
Yeah.
So if we apply that to this situation, in picture A, we're hitting the dirt or the sponge, right? There's enough compliance that that it absorbs that energy. Yes, it's a little more technical. And if we even make that pressure higher from a type 2, right, you still have that compliance to absorb some of that energy. Correct. Versus if we have a type 1, they have that stiffened ventricle. It's like hitting the brick where the hammer bounces. Is that fair enough?
Yes, that is correct. So we're talking about, so the primary question was whether or not you can distinguish different types of pulmonary hypertension based upon just the Doppler flow profiles, right? So if 1 would be the most commonly seen profile in group 2, which is left-sided or post-capillary, okay? You may see a mixed pattern sometimes, and that's not uncommon. So you may have patients with high LV filling pressures and have superimposed pulmonary hypertension, which is group 1 on top of that, and then you can see that notching, okay? Sure. So if we're talking about, so group B on the other, so picture B, I'm sorry, I keep calling it group B. Picture B is group 1 pulmonary hypertension, okay? Unless proven otherwise, okay? It can also be seen in pulmonary embolism because we're talking about a sudden decline in, an artificial decline, let's say, in the pulmonary arterial compliance, because it's like a sudden afterload increase, and that can produce that notch. Okay?
Well, you're also clogging up the entire system that would provide the compliance.
So the surface area is all gone. Now,
correct,
if you were to perform a right heart cath on these folks, okay, and this has been done, and this is one of these papers from Mayo Clinic, and I'll share the screen with you. If you wanted to understand this well, read this paper. It's in JACC Imaging from 2017 by Mayo Clinic. And the Mayo Clinic folks are some of the best in the world in echocardiography, okay? Garvin Kane is the director of the Echo Lab there, and he's a very bright man. So this is what I'm trying to show you, okay? So if you were to perform a right heart cath on a person with group 2 pulmonary hypertension, your pulmonary vascular resistance is going to be less than 3 Wood units, okay? And your vag pressure is going to be more than 15. All right, that's simple, right? Additional echo parameters that you will see are a group 2 or group 3 pattern of diastolic filling, okay? So we're talking about pseudonormal filling or restrictive filling, and a big or bigger left atrium and a smaller right atrium.
Sure. And just as a reminder, someone asked a question to review groups 1, 2, and 3. And so group 1 is primary pulmonary artery hypertension, the artery problem. Group 2 is left ventricular problem. And group 3 is the chronic hypoxic lung disease problem, with group 4 being chronic thromboembolic problems.
Correct. Exactly right. So we're talking about, so now there are patients with both group 1 and 2 who can have a B-like pattern, but a B pattern, which is the mid-systolic notching in isolation, is most likely to occur with group 1 pulmonary hypertension.
Mm-hmm.
Okay, and that is because the issue lies with the pulmonary vascular resistance, and it's usually more than 5 Wood units if you get this pattern, but you have different levels of sensitivity and specificity for whether it's 3 Wood units versus 5 Wood units. It becomes more specific at 3 and it becomes more sensitive at 5. But again, suffice it to say that your PVR is going to be high in these patients, and you could have concomitant high left-sided pressures as well. It doesn't exclude the coexistence. So when I look at my echo, if I see a high E wave and I see a restrictive pattern and I see this pattern, then I know that I've got 2 processes going on, okay? Mm-hmm. That has been shown in correlated right heart cath studies repeatedly. So yes, you can distinguish between the types of pulmonary hypertension by this flow pattern. You can. Okay, now let me take you.
And for that E wave pattern, go back and watch last week's video to those of you guys on the chat. We talked about it.
If you have not done so, yes. I did not attend that talk, so I don't know exactly what was talked.
Yeah, I'm just trying to give context so people were throwing a lot of stuff at them.
Brilliant. Okay, now we're looking at the time to notch. I'm going to make this a little bit bigger so that you guys can see this properly. And there it is. Now they went a step further in these group of patients. Okay, now we're talking about patients with only group 1 here. Okay, all right. So we're not talking about other groups. You have the mid-systolic. You have the mid-systolic notching here, right? Mm-hmm. You have the pre-velocity, which is the velocity to peak for the first peak, and then you have the notch velocity, and then you have the post velocity, right? So you can have many, many different measurements, okay? Sure, I don't want to confuse you guys, but there's something called the deceleration slope as well. Not just the acceleration time goes from here to here, right? Mm-hmm. And then the deceleration slope is the time it takes for this to recover all the way. It may not recover all the way, but if you drew the line, it would take you. So the sharper that line, the shorter the deceleration slope, the higher your pressure, okay? And then, as you can imagine, the right ventricle has to recover its function and start ejecting again, right? If the right ventricle has good function, it will recover and give you a good high post velocity, right? However, if you don't have a good high post velocity, that means your RV is failing. Okay. Mm-hmm. So, right. So you're talking about group 1 pH. The earlier you see the notch, the higher the pressure. That's number 1. That means your deceleration slope is going to be sharper. Mm-hmm. And on top of that, if you had a low post velocity, you're going to do even worse. Because now, in addition to the poor arterial compliance, you're talking about poor RV function. Okay, so there's a greater disconnect between the right ventricle and the pulmonary arterial system. Okay, all right. Does that make sense? I think there's a question in the chat. Can you see it? Can you read it? I don't know if I can.
We covered that one. That was the review of the different types of
Okay.
hypertension. Yeah.
Is this clear?
Yes. Yeah. Does anyone have questions on this? I know it's kind of complex. We're talking about the dynamics of the length of time from, and maybe I'll just recap it, right? Just so to make sure I got it. The amount of time, or the amount of time that it takes to go from 0 to 60, right, is a reflection on your peak pressure, your pressure, and the amount of time it takes to decelerate. Well, actually, we should say the amount of time it takes to decelerate is your reflection of your pressure, and the height of your post pressure, that post notch pressure, is related to the strength of your ventricle, whether it's high, good, low, failing. Did I summarize that correctly?
Yes, you did. So let me show you something else to make that even more clear, right? So this is the sort of a summary figure for this whole paper, okay? So if you look at this, so the RV outflow tract envelopes in patients with pulmonary arterial hypertension, so PAH, group 1, okay? You can have non-notched envelopes, which are the patients with the best prognosis. Only 9 patients in group 1 had non-notched envelopes, okay? So that means that you're not going to see it very often. So if you see this non-notched pattern, it more often means left-sided pressures, high left-sided pressures, okay? But you can get this in patients with group 1 as well. You don't have to have a notch in patients with group 1 PH. I want you to be very clear about that, but it's a smaller number of patients depending upon how high your pressures are. So if you're talking about PS systolic pressures and mean pressures in the 70s and 40s respectively, then you're going to see a lot more of notched patients, right? Now, when we're talking about in terms of prognosis, you have a little bit longer deceleration time in about 100 patients here, which is going to be the majority of these patients. So the deceleration time I showed you on the previous sort of discussion, if it is more than 120 milliseconds, you're going to have the best prognosis. See that? See that it's kind of a gentle upslope, and then you have the second peak here. Okay? As the mid-systolic deceleration time becomes less than 120 milliseconds, which is an even smaller number of people, you can then break it down into the pre and post velocity, right? So the higher your post velocity, the better you're going to do. And the lower your post velocity. So this is incrementally bad prognosis going from left to right, okay?
Sure.
So long deceleration time and then short deceleration time, which is divided into the post velocity to pre-velocity ratios, okay? Now, this is obviously becoming more complex, but I'm going to show you one summary sort of graphic here, which will make it very clear. Now, we're talking about prognosis now, right? I hope you can see this figure, okay? And I'm going to try to make this a little bit bigger if you don't see it. This is the Kaplan-Meier survival curve, and there's no better prognosis than survival, right? So we're talking about survival here, right? So in the green line, no notch. That's your top reference standard here. Then the long deceleration time, which is in this salmon pink color, does slightly worse. And then we're talking about a short deceleration time in the blue line with a high V post velocity. And finally, in this sort of yellowish green line, you have this short deceleration time with the low post velocity, which is the second velocity profile that you see. And these are the patients that have the worst prognosis, okay? I hope that was clear. That's because that's the point I wanted to make sure everyone understood.
Yeah, no, that's great. I think as time is coming to the end here, we probably need to land the plane a little bit. We talked a lot about kind of differentiating pulmonary pre and post capillary pulmonary hypertension with these the RVOT packets essentially, and with with the notching and all that. When it comes down to the original question, can you use, if we compare acute thromboembolism to let's say chronic pulmonary hypertension, and I guess it was we started off in a little bit of an unfair place because we didn't define what our cause of pulmonary hypertension. Let's assume type 1, right? And we draw that VTI curve and we get a number, right? So we have a 10 and we have a 15. Can we use that number, that raw number, to make that differentiation between acute PE versus chronic pulmonary, type 1 pulmonary hypertension?
I don't think you can, right? But you can, so in the acute PE situation, you're going to have a lower TVI than the group 1 patient who's sort of compensated so far, right? So if your group 1 patient is doing reasonably well, and they still are maintaining a decent cardiac output and index, their VTI is going to be much higher than someone with a large, massive embolism. And that is reflective of the cardiac output, really. Where the notching occurs and all that, you guys have previously discussed, you know, the earlier the notch, the bigger the PE, because that's kind of telling you, you know, the cardiac output is stopping early, and therefore the embolism is probably more proximal. That's kind of my take on how it works. But the acceleration time is going to be less than 60 milliseconds in most of these acute PE patients, but your overall PA pressure is going to be quite a bit lower than your group 1 patient, right? So in the acute PE situation, your PA pressure should be less than 60. Obviously, you're not going to do a right heart cath on someone with an acute pulmonary embolism because you don't want to put a swan in someone with a blood clot.
May not work.
That wouldn't be a good idea. So, and that's where echo comes in really handy. It does a fantastic job. So on your echo, you have to look at the eccentricity index as well. This is one more thing I wanted to talk about. So, you know, if your right ventricle is much bigger than the left ventricle and it's kind of pushing into the left ventricle, that means it's predominantly a group 1 issue, right? If they're balanced in size, those chambers, and same applies to the right atrial area versus the left atrial area. If the right atrial area is significantly larger than the left atrial area, then we're talking about mainly group 1, right? Group 2, again, I want to go back and make sure you remember that group 2 is left-sided, and you'll see a much bigger left atrium and potentially a bigger left ventricle, although, you know, if you're talking about significant diastolic dysfunction, then both chambers may be the same size. In fact, you can have a larger right ventricle in group 1 as well, depending upon how much secondary pulmonary hypertension is developing. And despite that, you're not going to get the notch. This is a very nice paper from the University of Pennsylvania. So this is a really, really good group of authors, and it was in collaboration with Boston Children. So it was published in one of the pulmonary journals. This is, let me see. So this is the American Journal of Respiratory and Critical Care Medicine. So I'm sure the pulmonary folks are very familiar with it. It was published in 2011, and the first author is Jeffrey Arkels. The reason I know one of the authors, Dr. Ferrari, who's a cardiac MR specialist and also an echocardiographer at Penn, and they really showed this very, very nicely. Okay, so these are the various patterns of the flow, and they kind of talk about the same things that I've kind of summarized for you in on the basis of the Mayo Clinic paper. So, you know, we're talking about these two groups really kind of agreeing with each other at different points in time. This paper was published in 2011, and the other one was published in 2017, but it kind of shows similar things. This paper from Penn, you know, included patients with you know, group 1 and 2. So I think that's where the beauty of these papers is they kind of make the same point without with different populations in mind. So I would highly encourage you to look at those two papers, and that'll actually make a lot of sense for you.
So maybe just to do a final summary, and Ashish, thanks for coming on. This has been amazing. It's every time I have you and Dr. Shaman on to discuss these things, I mean, I'm learning a ton of stuff in real time as we go. So thanks for doing that. But in summary, to answer the original question that we set out to say, can you use RVOT VTI to differentiate PE versus pulmonary hypertension? The answer is probably not. And the reason is there's a lot of factors that come into play, but really, how well does that RV accommodate, you know, the elevated pressures, right? And so if you can compensate with your RV, it shouldn't really ding your RVOT VTI in terms of the total packet volume or total packet area versus an uncompensated process. And both of these can exist in compensated or uncompensated states. And so I think from that perspective, probably not going to be that helpful in indices to differentiate the two. However, when we get into some of the nuances of the packet morphology, whether it's notching and where that notching happens to be, there's a lot of degree for nuance. And I think we're going to have to leave it there and just make that a teaser for an upcoming lecture at some point here about using looking more at the notching. And one of the maybe things that I think would be fun to look into is prognosticating PEs based on your post-notch velocity, which could be kind of an interesting thought. And Ashish will kind of plant that seed, and we'll have that conversation down the road here.